Doctors Association for Relief and Education.
Now we'll start with the first session of the program, the Acute Stroke Management by Dr. Mukheem Mudabbir. He is MBBS from Osmania and he is DEM Neurology from NIMHANS. I request Dr. Mukheem Mudabbir to come and present his topic.
We are here to discuss about acute stroke management. Firstly, I would like to thank Almighty for giving this opportunity for all of us to gather here. Secondly, I would like to thank the DARE organization for giving me this opportunity to speak in front of you on this topic. So, before starting this topic, I just want to introduce myself. I am Dr. Mukheem Mudabbir. I am a consultant neurologist in Continental Hospital, Gachibowli, and I am also a visiting neurologist at Maitri Hospital, Mehdipatnam. So, let us start this topic today. So, coming to definition, what is stroke? I mean, what actually mean? Stroke or cerebrovascular accident is defined as acute onset of neurological deficit due to vascular etiology. So, any neurological deficit happening because of vascular etiology is considered as a stroke. So, this stroke can be because of ischemic stroke or it could be because of hemorrhagic etiology. So, another definition which we need to understand before going into topic per se, what does transient ischemic attack means? So, it is a brief episode of neurological dysfunction due to focal brain ischemia, that is lack of circulation to the brain region, happening so transiently that the deficit should not last more than an hour, and there should not be any evidence of infarct in the imaging. So, keeping this definitions in mind, we will go ahead with further discussion. So, as I told you in the previous slide, stroke is because of, it could be because of two reasons, that is ischemic stroke or hemorrhagic stroke. What does ischemic stroke mean? Ischemic stroke mean it is due to the stroke happening, the brain damage happening because of obstruction to the blood vessel, because of which the circulation will be hampered in the brain region and the brain get damaged. Whereas the second type of stroke is hemorrhagic stroke, that is due to rupture of the blood vessel and there will be extravasation of blood, and subsequently there is adjacent area, the subjacent area which is where the blood rupture has happened, blood has extravasated, the brain region will get dysfunctional. So, this chart here you can see the majority of strokes are because of ischemia, that is ischemic stroke, lack of blood circulation to certain brain region. That type of stroke is so common when we come across in our daily practice. So, in the studies which has done earlier, so many of the studies, their epidemiological data is showing that the ischemic stroke can be somewhere between 70 to 90%. So, now why just I want to show you this is I am taking this topic further, concentrating only on ischemic part, because that is the most common type of stroke we encounter in our practice. So, why we have chosen this ischemic stroke topic? We know very common topic. Before just taking this topic, I mean, whenever we come across that someone is talking on stroke, we will be having one thought that why again stroke, why, it is a common topic, right? So, the reason for choosing this is because in our daily practice, any practitioner who is practicing in Indian scenario, almost 500 to 600 the incidence is very high in Indian population. We know that this Indian population registries are very poorly maintained. Still, in these poor maintenance registries also, we are getting, it could be ALS and so many conditions, they are not treatable. Okay, otherwise partially treatable only. But whereas in strokes are, they can, if on time, if we intervene, if we treat the patient on time, there could be 100% improvement chances in them. So, I am focusing, as I said, I am focusing on ischemic stroke part because that is the most common type of stroke we encounter in our practice. So, before going further, I just want to overview my topic, what I am going to discuss in my topic. So firstly, I would like to go ahead with IV thrombolysis. Second, medical management, if we miss IV thrombolysis, if the patient doesn't come on time, so what medical management we are going to follow? Or else, post thrombolysis, what medical management we are going to follow? And third, role of surgical management in patients of ischemic stroke. And last but not the least, that is rehabilitation, the role of rehabilitation in patients with stroke. So we always come across, whenever we are talking about stroke, we always listen that time is brain, time is brain. Why this being said? I mean, why time is brain? Ischemic stroke is highly time sensitive. So the more the time you take to treat the patient, the more neurons you will lose. So for example, if you can see here, for each minute of ischemic stroke, an estimated 2 million of brain neurons will die, whereas almost 13 billion synapses will be lost. So one of the study has shown that 1 hour of ischemic stroke will lose neurons as much as 3 to 6 years of normal aging process. So compared to cardiological myocyte, if you can compare cardiac myocyte, the neurons are so time sensitive. They are very much sensitive, and each minute, in fact each minute it is very precious for the patient for neurological recovery. So what background knowledge we should have to understand what we are going to treat? I mean, how we are going to treat any patient with a ischemic stroke or any type of stroke. So baseline knowledge should be CT. So in my further discussion, I am not going to talk anything on MRI, because the purpose of treating stroke patient on time is to save time. Whereas if you are taking MRI as an imaging modality, you are unnecessarily wasting time, thereby you are losing your precious initial hours. So for the same reason, I am not going to concentrate on MRI. It doesn't mean that MRI is not a superior modality. Of course it is superior modality. There are better information we can get by doing MRI, but we want time to be saved at this point of time. First encounter the patient, get things done as soon as possible. Don't waste your time. So CT is the investigation where on toes it can be done and you can save a lot of time. So what you should understand before reading CT. Here while reading CT, the density, that radio density we will calculate by Hounsfield units, that is HU. Okay. So one thing we should understand that whenever there is a metal in any of the object that we are about to study or region of interest, so that whenever there is a metal, the density will be more in CT. Whereas whenever there is a water or fat, the density will be less. So in what way it is important, in what way it is relevant to our stroke management or stroke, understanding the stroke part. So here whenever there is a stroke, there will be water retention happening in the cell. Okay, so compared to the normal water Brownian motion, whenever there is a stroke happening in any person, any brain cell, so that will cause water mobility restriction. Thereby there will be hypodensity happening in the CT. So what we should understand is, whenever there is hypodensity or whenever there is density which is lesser than the subjacent brain areas, so that could be because of ischemic stroke. Whereas the only reason we are doing CT here for any patient is mainly to rule out hemorrhage. So as we know, blood is rich in iron. So whenever there is a metal, the CT will pick it up as hyperdensity. So whenever there is a hyperdensity, that means it is due to hemorrhagic stroke. So the main reason for doing CT is to differentiate between ischemic stroke and hemorrhagic stroke. CT is the best immediate available modality to rule out hemorrhage. So because here the treatment plan in acute setting will differ for the patient with ischemic stroke compared to the hemorrhagic stroke. So we need to pick the patient who is not having hemorrhage and having ischemia as possibility for a neurological deficit. So the second thing what we should understand here is the circle of Willis. So here we will be discussing our further topic, mentioning that large vessel occlusion. So what does exactly large vessel occlusion mean? It is basically, we know that internal cerebral artery, this internal cerebral artery will get divided into anterocerebral and middle cerebral artery. Whereas the posterior circulation, so we call our brain circulation anterior circulation and posterior circulation. What does anterior circulation mean? That is the supply which is provided from the internal cerebral artery. Okay, so the internal cerebral artery related circulation is called anterior circulation, whereas posterior circulation is basically because of basilar artery and its branches, that is posterior cerebral artery. So what are large vessel? What exactly mean by large vessel? Large vessel means basilar. Mainly it is the basilar part. Okay, this is the basilar part. These are vertebral arteries. This is the basilar artery and this is the posterior cerebral arteries here. Okay, so large vessel artery means it should be either basilar artery, posterior cerebral artery, internal cerebral artery, otherwise the major one their branches, that is middle cerebral artery and anterior cerebral artery. So these are large vessel. So the areas, the vessels which are important in acute stroke management are basically distal basilar, distal ICA and proximal MCA. Okay, this you keep in mind so that you better understand what I am going to tell in the coming slide. So before treating any patient in ischemic stroke, okay, so two things we should keep in mind. What is NIHS score and what is aspect score? So NIHS score is basically a scoring system given for the patient's neurological deficit. It contains all the neurological part, level of sensorium, patient's ability to comprehend, patient's language abilities, brief examination of cranial part, extraocular movement, facial asymmetry, limb power, limb sensations. So the maximum score is 42, but in a given patient, when we talk about hemiparesis, one-sided weakness, the maximum score possible is 30. Okay? So why this scoring system is important is, based on the score, we can take a decision what type of approach we are going to take in the patient's care. Coming back to the second part, that is aspect score. Aspect score is basically Alberta stroke. This is one of the scaling method where at the level of basal ganglia and above its level there will be some regions, like what we can say the brain regions, when what we see in the CT at the level of basal ganglia and 10 on each side. Okay, so each point will be given for the basal ganglia, caudate, lenticulostriate, internal capsule, insular, and M1, M2, M3 are middle cerebral artery territories. Those are basically frontal regions and temporal regions which are supplied by middle cerebral artery. And here you can see these are almost 7, each point given for each region. Whereas on its upper level, the same corresponding regions here is coming to our emergency department with acute onset neurological deficit due to suspected vascular etiology, that is basically stroke patient. So whenever patient comes in window period, stroke in window period is basically the patient last seen normal, so from that point to the entry into the emergency room. So that time period is basically considered as very important. Whenever the patient comes within 4.5 hours or 6 hours, at least 12 hours. So whenever the patient comes within hours of neurological deficit onset, we consider it as stroke in window. Especially first 4.5 hours to first 6 hours are very much important. So whenever patient comes to emergency rooms within that window period, first what we follow, it is the same in any emergency department, that is airway, breath and circulation assessment, just to make sure the patient is in his stable hemodynamic status. Subsequently, we will calculate his NIHS score, his or her NIHS score. NIHS score, as I said, this is a scoring system where we will calculate how much deficit the person is having to better communicate between the doctors or medical professionals. Okay, so once you calculate this NIHS score, you will do the second thing important is measuring the glycemic status of the patient, because hypoglycemia is a major mimicker for any sort of focal deficit. So you will make sure that patient is not having hypoglycemia. So whenever this person is having less than 60 or less than 50 of sugars, you first correct that and wait for the improvement to happen or not happening. So if it is due to neuroglycopenia, it should improve within few minutes of glycemia correction. Subsequently, the checklist you will follow. I mean, the whenever person is not having low sugars and patient's BP is not more than 185 by 110, that is 185 systolic and 110 diastolic. Once you make sure that sugars are normal and BP is normal, you will just check the contraindications and indications checklist, what we will follow for any patient with thrombolysis. Okay. Subsequently, we will take the patient to the CT brain part. So in CT brain, we will rule out hemorrhage. So once the patient is not having hemorrhage, and patient is coming within 4.5 hours of stroke onset, and CT is not showing any hemorrhage, we will directly proceed ahead with IV thrombolysis. That is intravenous injection, tissue plasminogen activator, which we will give to dissolve a clot. Okay. So then subsequently, once you give your thrombolysis, the one part of your treatment is over. Then you will see the CT angio part to look for any large vessel occlusion. Okay. So what is large vessel occlusion? Just we have discussed that this is circle of Willis. What we are looking into proximal MCA or distal ICA and basilar artery. Okay. So if there is any large vessel occlusion, you will push for mechanical thrombectomy. So this is same continuation of whatever I said. Whenever this patient is coming within window period, NHS score on arrival, get the CT as soon as possible. I'll calculate the aspect score. So aspect score is important here because if there is aspect score less than 7, the recovery chances post thrombolysis is less. So whenever patient is having 10/10 aspect score, that is patient is not having any hypodensity in any of the regions what I showed in my previous slide, then the chances of recovery will be more. Then administer IV thrombolysis, then go ahead with CT angio and look for any large vessel occlusion. So we will utilize which has clot dissolving properties. So we will utilize that property of plasminogen by recombinant. So it is given in patient with ischemic stroke with an intention that hypothetically it will go and dissolve the occlusion of the vessel, thereby restoration of blood flow. Thereby it will help in restoration of blood flow and it will help to increase the circulation to the deficient brain region and it will help in recovery. So what is IV thrombolysis? IV thrombolysis, basically the tissue plasminogen activator, it was first introduced in 1996. Okay, so if we give IV thrombolysis within 3 hours, the number needed to treat, to see one good outcome, number of patients need to be treated is 10. So 1 in 10% after giving IV thrombolysis within 3 hours, the recovery will be seen. Whereas if you delay it for 1.5 or more, the number needed to treat will be 20. That means for one good outcome, you need to treat 20 patients if you are treating them within 4.5 hours. So every 15 minutes, reduction in time in your IV thrombolysis injection administration for patients with ischemic stroke, the odds of walking out of hospital will be 4%. What are availabilities in our practice to be given in patient with ischemic stroke? We do have RT plus and we do have tenecteplase plus. So these two IV thrombolytic agents, the tissue plasminogen activators, we do have in our market. But tenecteplase plus, it has recently come into market. RT plus are, one is low cost. If you take RT plus, the cost will be approximately 40 to 60,000. Whereas if you take tenecteplase plus, it will be almost 20 to 25,000. So there will be significant less cost compared to the RT plus. And second is administration method. Tenecteplase plus can be given as a bolus, whereas RT plus needs to be given as an infusion. As an infusion it has to be given, which is basically a cumbersome procedure in an acute stroke care management setting. And third is, as tenecteplase is a active component of RT plus, it will be more fibrin specific and has longer duration of action. So we should understand tenecteplase, it will act basically tenecteplase and RT plus, they are tissue plasminogen activators. That means they will activate plasminogen and convert it to plasmin. The plasmin is the main component which will dissolve the fibrin clot mesh which will be there in patient with ischemic stroke. So what are the contraindications we need to look into before administering recombinant tissue plasminogen activator? Among these, the important is basically hemorrhage. Patient should not have intracerebral hemorrhage. There should not be any major head trauma happening within last 3 months. There should not be any ischemic stroke in the last 3 months. There should not be full dose anticoagulant administration happened in the last 24 hours. And there are, apart from that, there are set of contraindications which we need to look into. Okay, so what are the predictors of tissue plasminogen activator failure in patient with acute stroke? So these things, when they are there, the chances of success will be less. Okay, so when there is a large vessel occlusion, the large vessels what we discussed about, and when the aspect score is less than 7, when the NHS score is more than 22, and when the thrombus in the large vessel there is a thrombus size more than 8 centimeter, and of course more than 4.5 hours of stroke onset. So if these things are there in patient, then the success rate of thrombolysis is less. So what medical management we will follow subsequently after thrombolysis, or patient is coming after the said window period, then what medical management we will follow? Here, any patient who is coming out of window, we should start dual antiplatelet and high dose statin as soon as possible. Ideally speaking, within 12 hours, if not, as soon as possible within 24 hours. Whereas post thrombolysis, the patient has come within 4.5 hours and you thrombolyze the patient. So when we should start for subsequent medical management? The statin can be started as soon as possible within 24 hours, but you have to wait for dual antiplatelets for at least 24 hours, because post thrombolysis after 24 hours, you have to do an imaging to look for any hemorrhagic transformations. Then if you are certain that there is no hemorrhagic component happening, then proceed ahead with dual antiplatelets. In both the above groups, with or without thrombolysis, okay, without or with thrombolysis, the dual antiplatelet should be continued for at least 90 days duration, then you can convert into single antiplatelet. Whereas high dose statin has to be initiated for acute stroke patient, and it should be continued with the LDL target of less than 70. Coming to, for any patient with stroke, ischemic stroke, the main management will be dual antiplatelets. Okay, so there are very few indications for anticoagulation, that is heparin, low molecular heparin, and other sort of anticoagulation, oral anticoagulants. So there are very limited indications for anticoagulation in patients of ischemic stroke management. So any patient with acute ischemic stroke or transient ischemic attack, if they are having any of the following causes, then the anticoagulant indication will be more compared to the antiplatelet. Here the indications are left ventricular left atrial thrombus, left ventricular assist device, atrial fibrillation, it could be valvular or non-valvular, atrial flutter, mechanical heart valves in the mitral and aortic valve region, antiphospholipid antibody syndrome, or cyanotic or complex congenital heart diseases. So if these are there in the etiological workup, the indication for anticoagulation will be coming into picture. So what etiological workup? We know when the patient comes within 4.5 hours, we know how to thrombolyze, we know how to do medical management subsequently. Now we have to do basic workup to understand why the stroke has happened. So if you can see in this flow chart, I mean here this part of the slide, if you can see, so the stroke is basically in 80 to 90%. As I said, somewhere between 70 to 90% of the cases the stroke is because of ischemia. Okay, so in 80 to 90% of cases that is due to ischemic part. That, and among the ischemia, so major chunk is because of non-lacunar strokes, whereas only 20 to 25% cases are due to lacunar strokes. So in these 75% of non-lacunar strokes, mainly the etiology will be either cardioembolic or it is due to large artery source. So the non-lacunar stroke etiology will be predominantly cardioembolic or artery to artery embolies, that is large artery related stroke. Otherwise, in almost what I can say, in 20% of the cases the etiology will be cryptogenic, that is etiology is not immediately found. So in these cryptogenic strokes, the 50% are due to embolic stroke due to unknown source. So this is very important here. When we know that this is not a lacunar stroke, then we should look into the cardiac source and large vessels as a source. And if still we don't find any, then we should consider digging it further to rule out any embolic stroke of unknown significance. So this slide is basically showing the workup what we need to basically follow. For any patient with ischemic stroke, basic investigations what we have to do is ECG, 2D echo. When it is the stroke is due to anti-circulatory strokes, carotid Doppler is important, and subsequently other investigations, like let's say if we know the source by this means, like if the 2D echo is showing the clot in the ventricle or in any large vessel occlusion is there in the carotid Doppler, what we will perform, we are okay that we found the cause. If let's say we don't find the cause, then we need to dig it further. The patient, especially in the patient with having recurrent strokes, we have to do transesophageal echo or bubble contrast echo to see any patent foramen ovale type of congenital heart diseases. So in this type of congenital heart disease background, patients are more prone to get strokes. Okay, so this is important to look into, especially in the patient with recurrent strokes. So what else we need to look into? We need to basically understand patient's risk profile, that is whether the patient is diabetic. Okay, if not, the patient is not a known diabetic, we need to look into the HbA1c status and the patient's glycemia control in the last 3 months, by which we can understand it by doing HbA1c. And apart from that, so other investigations like lipid profile and basic investigations can be done. So based on the etiological cause what we find, we will target the lifestyle modification and future prevention of the stroke. Let's say patient is having hypertension, the target blood pressure should be less than 140 systolic, we should focus on by giving medication. Whereas if the patient is having abnormal lipid, especially LDL, the target will be to reduce the LDL by giving medication. The target should be to reducing the LDL to less than 70 and focusing on diabetic control. And as I said, 90 days, that is 3 months. And if we find any of the cardiac source, targeting on giving anticoagulation. If we don't find any of those cardiac source, then focus on the antiplatelet part only. Okay, if we find any patent foramen ovale, then focus on closure. And if we find any of the carotid Doppler is showing any carotid occlusion, I mean carotid extracranial part of the carotid, if there is any occlusion of symptomatic side, that stroke side, then we should plan for end arterectomy in this. So what is the role of surgical intervention in any patient with ischemic stroke? So we know that stroke can be very small and it can be very large. So if the patient did not get corrected with the thrombolysis, or patient is coming after the said window period and already the infarct has well set in. So as we know, any part of the body tissue, whenever there is a damage, there will be swelling in that part. So the same way, the same thing will be applicable for the ischemic stroke also. Though here, unfortunately, the brain is well embedded or well situated in the bony compartment. So whenever there is a swelling in the stroke region, there will be no space to expand. So it will expand by means of compressing on the normal brain. So that's what we should look into in patients with ischemic stroke in initial part. Whenever there is a large stroke, when we consider the patient is at high risk of possible surgical intervention, whenever there is more than half or 2/3 of empty arterial infarct or cerebellar infarct. So if these are there in a patient with stroke, so the chance we should very closely look into for any surgical management in this patient. So what exactly we will do? Let's say patient is having, in this example, the patient is having almost more than half the MC territory infarct here. So that is having edema, it is compressing on the subjected normal brain. Then we will remove this bone flap here and we will create the space for the brain to expand on the outer side than on the inner side. Thereby further neurological damage can be prevented. So what is the best timeline to do this? So whenever this is there, that is more than 2/3 or one half the MC territory infarct is there or cerebellar infarct is there, you should have very close observation, neurological monitoring for the patient. So whenever there is dip in sensorium level or the follow-up imaging is showing at the level of septum pellucidum, if there is midline shift of more than 7.5 millimeter, or at the level of pineal gland, if the midline shift is more than 4.5 mm, then we should be in rush to do decompression craniotomy to avoid further brain damage. Okay. So the usual cerebral edema will progress up to 5 days in any patient with ischemic stroke. So for any large strokes, keep close neuro observation for initial 5 days, but maximum chances of decompression will be more in first 2 to 3 days. Okay. So this additional medication we will be coming across in any patient with ischemic stroke. One is patients will be prescribed anti-epileptic drug like levetiracetam, and patient will be given all sort of medication. So what we should understand, do they really have the role in patients of ischemic stroke? Anti-epileptic drugs has role only in patients with stroke having seizures. There is no prophylactic type of thing which is recommended in patients with ischemic stroke. That too, how much duration we should be closely observing for seizures in a patient with ischemic stroke. That is, first 24 hours period is the high risk period where there are possibility of seizures happening in these patients because of the local changes happening in the brain tissue. Okay. So if the patient is not having seizures in the first 24 hours, it is very unlikely that the patient will be having in future. There is a second thing, that remote symptomatically after few hours because of glycotic focus, patient may have that, but acute stroke per se causing seizure is very unlikely after 24 hours. Coming back to paracetam. Paracetam basically is an antioxidant drug. We come at ceticolin, paracetam, all these drugs are not having a proven role in patients with ischemic stroke. Coming back to fluoxetine. Yes, fluoxetine is basically antidepressant drug. So it has a role in patients with left MCA territory infarct having language deficit. Fluoxetine has a role for language improvement. Coming back to multivitamin. Multivitamins can be given, there is no harm in, but per se the recommendation doesn't suggest that. The recommendations don't suggest administering multivitamin. Whereas antacid, it is important to understand that clopidogrel as well as pantoprazole has interaction. Pantoprazole has interaction with the clopidogrel, that it will reduce the efficacy of the clopidogrel. So when we are giving any patient, empirically giving antacid, please make sure that patient is on, if the patient is on clopidogrel, please try to avoid pantoprazole. Okay, you can give esomeprazole, labeprozole, that type of antacid protoporphyrin inhibitors you can give. Coming back to the last, one topic, that is rehabilitation. So it is very important for any stroke patient to start rehabilitation. So basically rehabilitation is making the person mobile and giving him the ability to cope up with his deficits. Okay, it has to be when it should be started, post stroke, when it should be started. So recommendations say rehabilitation should be deferred in first 24 hours. Aggressive rehabilitation should be deferred in the first 24 hours. After that, you can start rehabilitation as soon as possible. So any patient with weakness in the lower limb, whenever the power in the lower limb is less than 3, we should immediately focus on starting DVT prophylaxis. So DVT prophylaxis in the form of pneumatic compression stockings or by giving prophylactic dose of low molecular heparin. In the person should not develop bed sores, and frequent mobilization of the person using alpha or water beds, and subsequently dysphagia assessment and aspiration risk assessment. The person is having weakness of bulbar muscles and having risk of aspiration. In those patients, try to provide long time planning for peg tube insertion. And when should we start baclofen? Basically, the person post-stroke will develop spasticity. That is because of excitatory, the inhibition of the and there will be spasticity developing in patients with a person of ischemic stroke. The spasticity will develop as soon as possible, as soon as 7 days of post-stroke duration. So baclofen should be initiated whenever the person is having spasticity. Let's say if the person is not tolerating oral baclofen, we can still try intrathecal baclofen in them. If still the patient is further continue to have spasticity which is hampering his mobility, then we can consider giving botulinum toxin in them, especially in anti-gravity muscles, that is upper limb flexors and lower limb extensors. So by this I would like to conclude this topic, and this is the campaign what we will follow in our general public. So Be Fast campaign is to make the people understand that time is very important, and whenever you have issues with balance, difficulty in seeing, having facial deviation, difficulty in lifting arm or any difficulty in speech, please rush immediately to the nearest medical facility. Thank you.
Assalamu alaikum. Recently I have seen one patient, he is himself a doctor, MD, general medicine, he is suffering same stroke. patient came to me, he is himself a doctor, general medicine, MD, but he is having the same symptoms as you told before. About the response to removal of the this tube after this same attack of cerebral palsy and this ischemic heart disease, the patient bedridden, not respond to any this hemiplegia symptoms. So how to maintain this one to control the asphyxia? So the doctor asked me how long the treatment will be continued in the hospital or can be discharged.
The second question, the first question which you asked, so what will be the, after giving this treatment, what will be the neurological outcome?
Yes.
That's what you are asking, right?
Yes.
Basically, one thing is sure that whenever there is a neurological deficit post-stroke, the neurological recovery will happen either by the way of thrombolysis or thrombectomy. If it happens, it should happen immediately. If not, the neurological recovery will be by natural recovery. That can happen up to 2 years of age, but the maximum deficit improvement will happen in do rehabilitation as much as possible in the first 3 to 6 months, because that is the phase, that is the time period where the neuroplasticity will be more and the recovery chances will be high. And that topic per se, so I don't want to complicate this topic by discussing.
No, sorry for the topic.
No, not at all.
Continue as well as Leopil tablet to control convulsions. How long we continue this medication, because we use the
Anti-epileptic drugs you are talking about?
Yes,
anti-epileptic drugs. See, that is completely different thing. That is how to manage a patient with status epilepticus or something.
Yes.
So, I mean, nowhere related to this one, but yes, if you ask me, any patient with seizure, which is not subsiding on its own and
Yes.
taking, I mean, more time, that which warrants administration of drugs, if that is the scenario, whenever you are first time encountering the patient in active seizure, first give benzodiazepine drug, that is either midazolam or lorazepam. Subsequently, take any of the available anti-epileptic drug. Levetiracetam, yes, you can give. If you are giving levetiracetam in a patient with status epilepticus, make sure that you should give that drug 60 mg per kg body weight, not less than that, not 20 mg per kg body weight.
Okay.
There is equivalent dosages which we will give for anti-epileptic drugs. Those are very important in status epilepticus. Levetiracetam is 60 mg per kg body weight, valproate is 40 mg per kg body weight, phenytoin is 20 mg per kg body weight. These are equivalent dose. Don't give levetiracetam with 20 mg per kg body weight and see, I mean, expect an immediate response in them. So when you are dealing a status epilepticus, hit it hard by giving equivalent dosages.
Okay, thank you.